Hello, everyone. I'm Bill Zoghbi. I'm the chair of the Department of Cardiology here at Houston Methodist Hospital, the DeBakey Heart and Vascular Center. And with me is a pleasure to have Dr. Sanjiv Narayan. He's the professor of medicine at Stanford University and the co-director of the Arrhythmia Center there. It's a pleasure to have you here, and thank you really for a wonderful grand rounds this morning.
Thank you, Dr. Zoghbi. It's really been wonderful to be here.
What I really enjoyed about this grand rounds, and obviously we want our viewers to take a look at it, is not only is addressing atrial fibrillation from so many aspects. From its diagnosis, pathophysiology, some of the current challenges in a case-based approach, and hopefully some of the aspirations for the futures going forward. Even some of the intrigue to me was that we still can't diagnose it too well, even by a surface electrocardiogram, and the cardiologists have not done as well either in that evaluation. So the question to you is, obviously, the concern here is not necessarily only the symptoms of the patients, which, quite a few times we can address one way or another, but the risk of stroke, and how do we mitigate that? How do we decrease it? I have a question for you, and I've been hassling with it a bit, is nowadays with newer technologies, and those technologies have improved so much to be able to monitor the rhythm of an individual. And I can see in the near future, somebody being able to be monitored almost continuously, in addition to hemodynamics and everything else.
Yes.
If we have this technology, how much of a dent is it going to make in our therapeutics? Meaning, if I know an individual is in sinus rhythm, yet they're at risk of a stroke, am I looking at it correctly? Meaning, I'm looking at AFib as almost a symptom in a disease milieu. And if I stop that symptomatology, if I improve it electrically, etc., I'm still left with everything else that's with it. Am I in the right direction?
I think you're definitely in the right direction, and I think that's a forward-looking statement. I think that guidelines and evidence are pointing to the fact that AFib is almost just one of many risk factors for stroke. The others are the CHA2DS2-VASc score. Some people have already proposed in editorials and a few single center and retrospective studies that it should really be a CHA2DS2-VASc AF score, where your risk for stroke is heart failure, etc., with some number of points for AFib, because we know that people who have a moderately high CHA2DS2-VASc score are at risk for thromboembolism even without AFib. So therefore, to speak to the point you made about wearables and detection, I think that will make an enormous dent in our therapy, almost a dent that we're not prepared to take at the moment, we're not prepared to be able to handle. Because if you imagine, for instance, everybody with a smartphone, or let's say an Apple Watch, I see you've got one of those on. So, actually measuring their heart rate and having flash alerts of atrial fibrillation, then that would serve as a trigger to start looking for other risk factors, and people that never thought they needed to be could now be on anticoagulation that substantially changes the way that they might participate in sports and so on and so forth. So I think it's absolutely correct, but also it's a massive healthcare undertaking.
I'm just wondering, also on the other side of atrial fibrillation, is if we take AFib out of the equation and we have a score of heart failure, hypertension, so many other things, because at times we may not be able to detect atrial fibrillation. Yeah. And the question is, what is the risk of stroke in that population? Because that could be one factor, but it may be a very important factor by itself. I'm just wondering, from the reduction of stroke events down the line.
No, I think you're right. I think that there will be a group of people who don't have AFib despite monitoring, whose CHA2DS2-VASc score is, let's say, pick a number 5, and they do have a substantial risk for stroke. It may not be the 7% or 8% you'd expect for that patient if they had AFib and a CHA2DS2-VASc score of 5. But I think it'll be substantial and probably worthy of therapy.
What do you think, looking into the future for the next 5 years, what do you think are maybe the newer frontiers in atrial fibrillation that either being tackled, or should we tackle the next 5 years to try to either understand it better, treat it better, or whichever way, I mean, you think about? Obviously, you're a thought leader in AFib.
Thank you. So I think that identifying a personalized risk score for stroke, which really gets at personalized mechanisms for stroke, will be number one, because it's urgent. It's a really critical issue that we have to address straight away. I think the next would be some way of identifying whether lifestyle changes are more useful in some patients than others, and are some lifestyle changes more dramatic and more effective than others. And then I think a third one would be using those pieces of information to help inform our ways to treat and ablate AFib. But I do put that third because, of course, most patients with AFib don't get to ablation, although, of course, it's what I do for most of my job. But most people, however, may be at risk for stroke and could change their lifestyle. So I think those are the key elements, let's say from the ACC's perspective.
I like this personalization because, to me, I think we've emphasized, and appropriately, the scoring mechanism that we have, which is mostly clinical, if you will, right? But there are other anatomic things and functional things that we really have not incorporated yet. And yet we do quite a bit of imaging, be it with ultrasound, be it MRI at times. I mean, with CMR, it's not going to be that ubiquitous, I would say. But conceivably, individuals who either are getting a transesophageal or an echocardiogram just wonder whether the shape, even, of a left atrial appendage, because on the right side you have an appendage that may be wider shaped and less constricted, if you will,
yes,
at the origin. Just wonder whether a shape would be important, whether the velocities, be it by ultrasound or MRI, would be important, even in sinus rhythm, or atrial fibrillation tells you something about it. So, and maybe some other biological markers beyond what we know from a clinical point of view. So I like this approach about personalized medicine.
Yeah, I think it's very important, and I think an area that I personally like is computational models or network analysis to try and piece together associations and individualize therapy in a way that otherwise we have a bit of a hard time, doing as human beings. There are associations now that we're going to get out of massive amounts of data that will be available. A lot of that will be noise, but if we're able to have clear phenotypes, so patients that we know have AFib, for instance, patients who unfortunately have other comorbidities that we know about, and then we can use ambulatory data from their watch or something sewn into their sweatshirt, I think that will help us tremendously to be able to understand mechanisms and tailor therapy.
Wonderful. I think this is an exciting field. Anything on the technological end that could be revolutionary the next few years, be it the ablation portion or some other technologies?
So I'll leave ablation to the end. I think that detection of AFib, those devices, will revolutionize the field. It seems pedestrian, but the same way that the availability of uniform time or the fact that we can communicate so readily with each other was revolutionary, although we had phones for 50 years. I think the fact that everybody will know their rhythm, everybody will know some measure of, you could get cardiac output, I think that will be revolutionary. And just like we all have smartphones, many of us are going to have wearables moving forwards. I think imaging, I don't know whether 3D echo, but some combination of functional characterization of the atrium will be key. Because at some level, stroke rate almost, has to be related to Virchow's triads. You've got the tissue structure, you've got contractility is one that tells you stasis, you've got flow that tells you stasis, and then some rheological measurement from the blood that's probably easy to measure. We just may not know how to integrate it. I think that'll be key. I think some surgical advances when patients are going concomitant surgery. I think currently the ablation approaches are based, in my opinion, on concepts from 20 years ago, and I think those could be improved. So you could have prophylactic surgery based on anyone undergoing, a stenotomy procedure for CABG, for instance, or valve replacement. And then I think there could be a scope for integrating EP forms of therapy with transcatheter therapeutics, so TAVRs or other forms of prostheses. And finally, ablation. I think that ablation is very tech heavy. So there's many different things. I think the focus personally on localized sources and trying to understand why they occur, where they're anchored, how they relate to MR, I think that's a very exciting field moving forwards.
It really is very exciting, and just we were reminiscing, this morning as to when we trained, and atrial fibrillation was just, a rhythm somewhere there that people did not pay as much attention to.
Bottom of the history list.
It's amazing how much more emphasis, more knowledge, and actually more knowledge that indeed it was a major cause for morbidity and mortality.
Absolutely.
That was not as much on the radar screen.
Absolutely.
So it has been really a pleasure having you here at Houston Methodist, and wish you the best of luck, and thank you for visiting us, and we thank you for joining us, for continuing your medical education and interacting with us on these channels.
Thanks, Dr. Zoghbi. Thank you to the group at Houston Methodist. It's been wonderful.
Thank you.